miss a video from the Aesthetic Clinics and Dr. Debraj Shome.
Preeti will not be able to join us for some personal, mishap. So we'll be starting the session now. And since Debraj is on the way, I request Shilpa Taneja to please go ahead with the first session. Shilpa is practicing in Delhi. She is a leading oculoplastic surgeon and doing amazing work in oculofacial aesthetics. And it's my proud privilege to introduce Dr. Shilpa. She has presented in numerous national and international conferences, and this year we had the annual conference of Oculoplastics Association of India, and she had done an amazing presentation which was very well accepted and very well discussed. So over to Shilpa now.
Good morning all of you. Thank you ma'am for such kind words. But you know, in front of Dr. Kasturi it's like Suraj ko diya dikhana, and ma'am is praising words about me. So this is the last year's AIOC 2019 and at Indore, when 4 of us had taken the same course, and it was so popular. We had both sides of the hall full. You can see the only one side, the other side was also full. So this year it became an invited session on automatically. Dr. Preeti, she's here in the photograph. She could not join us this time. Can I have a pointer please? She could not join us because of some personal reasons. Dr. Debraj Shome is just arriving in 5-7 minutes. I'll be taking up on Dr. Preeti's talk also. So I have 2 talks, starting with anatomy and then the Botox and facial aesthetics. So I'll be discussing relevant facial anatomy on cadaveric dissection, what to be beware of. Why the need to learn anatomy? For safe and efficacious injections, so that we don't make mistakes, and to achieve consistent results every time. Because once we know our anatomy well, we know what we are doing, and then we do the things right and we achieve the results consistently and we improve upon them. So there are a few videos I'll be taking you through, starting from the upper face. As we dissect of the skin and subcutaneous tissue, the most important structure here is the frontalis muscle. This is the only elevator of the brow, and usually it might fan in a V-shaped pattern from medial to lateral. In this specimen it is not like this, and can have 2 parts also instead of one whole structure. We must be aware of this danger zone. We can name it as danger zone 1. The supraorbital artery and the supratrochlear arteries come out of the supraorbital notch here, and retrograde injections of fillers can cause blindness. So we must always be clear about this. Supratrochlear arteries here, as you can see inside, has multiple deep branches. So when you inject fillers in the glabular area, do it superficially. Otherwise skin necrosis and vision loss can be one effect of it. Next, here we have the corrugator muscle, which starts from the bone. Either it goes vertically up or it lies here horizontally. It is deep. See here, this is the animated version of the corrugator muscle, and this is deep to the frontalis muscle. This is brow depressor. So its origin is here, and it either goes horizontally or vertically up. So when it contracts and pulls the things inwards and downwards. That's how it becomes brow depressor. So injections of neuromuscular agents should be deep initially, medially, and when you go superficially, they should be, when you go laterally, they should become superficial. When you inject here, the fillers, they should be in small amounts and in bolus, not in continuous fashion. So next, coming on to this supraorbital nerve here, it goes centrally onto the one side of the forehead. Injections of neuromuscular agents, the Botox when we give for frontalis muscle, it should not be very deep and we should avoid this area, otherwise pain and neuroma formations are very common in this area. So this is the area where supraorbital vessel nerve goes. This is the temporal area, next important area to be discussed. It is bounded inferiorly by the root of the helix and the lateral canthus inferiorly, and superiorly at the fusion zone of the frontalis muscle and the temporalis muscle. As we take off the skin and subcutaneous tissue, we see this superficial temporoparietal fascia. Below this superficial temporoparietal fascia is the deep temporoparietal fascia and the temporalis muscle. The important thing to know here is that the superficial temporal artery, as it goes up, it gives a frontal branch here, which is around 1 finger breadth above the brow. So when you inject, obviously when you inject fillers, you always aspirate first. When you inject, don't inject in this area. This is the danger zone again. And the next important vessel below this superficial this is the vessel here. It is little high up in this specimen. This is the next important thing. This is the middle temporal vein. It retrograde goes into the jugular vein, and actually injected into this can also cause death. So this is one important area to be taken care of while injecting fillers and neuromuscular agents. So when you inject in temporal fascia, temporal area, inject between the skin and subcutaneous, this fold, this skin and subcutaneous tissue, and the superficial temporoparietal fascia. This is the safe zone because the middle temporal vein is below that, and the superficial temporal artery, the location we all know now. This is the safe zone between the skin and subcutaneous and the superficial temporal parietal fascia. Don't go near this. Coming on to the mid face. In the mid face, the facial artery and facial nerve lies deep here. As the facial nerve travels up, it bifurcates and gives the branches, frontal nerve and temporal nerve, superficial temporal nerve. So be careful of, again it lies 1 finger breadth above the brow. Be careful when you are injecting in the temporal area. When we lift the skin and subcutaneous tissue, below this is the fat compartments which give the contour of the face. The fat compartments superficially are connected with the mimetic muscles of the face. The platysma in the neck, the smas in the cheek area or the mid face, and the frontalis muscle above. Below that are the deep fat compartments. They are the superior, middle and inferior malar fat compartments. When you are giving injections, in females you usually inject at the zygomatic eminence and in males at the malar eminence. So when you are injecting, be careful of these infraorbital nerves and vessels. Especially in cases of males, when you are injecting here, don't go medially because of the infraorbital nerves and vessels which are present here. So if you want to fill up the theatre of deformity, inject laterally and massage the filler medially. That is more advisable. Next important thing here is the facial vein, which is deep. So when you inject here in the fat compartment, don't go very deep. Inject superficially. If you go deep, you might cause hematoma and injections into the vein. Next is the perioral area here. The perioral area lies below the superficial fat compartment. This is the superficial fat compartment. Below this is the important structures of the perioral area. As you dissect this off, there is this zygomaticus major muscle and zygomaticus minor muscle. Above this, we can see this. So when we are injecting for crow's feet and we inject here near the lateral orbital rim, the zygomaticus major muscle is here. If we inject here, we might cause droop of the angle of the mouth and difficulties in chewing of to the patient. So we should not inject in the zygomaticus major. This is elevator of the lip. Next important muscle to be remembered is DAO, depressor anguli oris, which depresses the angle of the mouth, and the relation of it is with depressor labii inferioris, which is here. So this depresses the lower lip. You must inject here when you are injecting for lips. Inject in this area, never go medially, inject laterally, because you don't want chewing difficulties in the patient. Next comes the masseter muscle. It is the most powerful muscle in the body, as we all know. Lies deep to the deep fat compartments here. To distinguish it well, ask the patient to clench and you can actually feel the muscle mass here. It is very deep as to show. The needle will go for 1 centimeter in, and you inject then your neuromuscular agent for bruxism or masseter hypertrophy if you want to give Botox injections. So coming on to the vessels of the neck and face, the facial artery starts here, is deep, takes a tortuous course here near the angle of the mouth, is 1 thumb away from the angle of the mouth. Be cautious of this. Then it gives branches. The superior labial artery here goes to the superior lip, and the inferior labial artery goes here to the inferior lip. The superior labial artery here lies deep, and the inferior labial artery also lies deep to the DLI. As you see, depressor labii inferioris is above this artery. So when you do lip fillers, stay superficial. Don't go more than 3 millimeters. 2 to 3 millimeters is maximum where you want to inject. As the frontal artery goes, facial artery goes up, see this, the tortuous course. Around 1 finger breadth away from the ala of the nose, it becomes superficial. So when you're doing fillers for the nasolabial fold, you actually go down deep to the pyriform fossa, aspirate, touch the bone, and avoid the arteries here. As it goes up, gives branches, dorsal nasal artery and lateral nasal artery. This forms the danger zone again, because these are anastomosing with the columnar arteries and veins here. So beware, when it forms angular artery above, angular vessels above, you don't inject in the angular vessels above. In any case, the medial area is a danger zone because of inferior orbital vessels and angular veins. See the proximity of angular vein, and we all know, being DCR surgeons, that it is very prominent. Here it is deep in the around mid nose and becomes superficial at the radix of the nose. In nose, if you want to do fillers for correction, the middle zone, the center zone, if we divide nose into 3 parts, the upper part, upper 1/3, the middle 1/3 and the lower 1/3, the middle 1/3 is the safest to inject. And when you hold the nose and move it, there is this mass over where the skin and subcutaneous moves very freely. That is the zone where we want to inject. Radix also has anastomosis up, and below the dorsal nasal arteries have anastomosis with columnar vessels. So the middle third, where there is no anastomosis, is the area where you should inject. Usually the patients you will find have depression at the bone and cartilage junction, and you need to inject here only. So God has made things, easy for us, that you have to inject here, I will not give vessels here, as if he could see in future the facial aesthetics. So this is about the important points. Obviously, I can't teach all the origin and insertion of muscles and etc. But this is the points which we should be beware of when we are starting facial aesthetics practice.
Any questions for Dr. Shilpa? Basically, we all know that every muscle has an antagonist. So if we look to the muscle of the upper part of the face, we need the elevator, we need the depressor. So Shilpa has very rightly mentioned that the only elevator which pulls the muscle of the face is your frontalis. So when you have something pulling up, you need something to pull down. So there are 3 major muscles which pulls the muscle down. One is the procerus, one is the corrugator, one is the orbicularis. So these are the muscle which pulls the whole of the eyebrow down, and this is the muscle which pulls the whole of the eyebrow up. Supposing a patient has a very flat eyebrow, you need to lift the eyebrow. So where will you inject? you need to decrease the action of those muscles which pulls the eyebrow down. So you need to touch the orbicularis and you can touch the corrugator. So what will happen if you touch the orbicularis and corrugator? The frontalis will have a upper hand and it will pull it up. Exactly when you think for the muscle of the mid face, these are the muscles which are responsible for the beautiful smile. Right? When we give, show a smiley, the smiley you see the lips going up, and a sad face, the lip goes down. So the muscle of the mid face, they are always responsible for the elevation of the lips. So all the zygomaticus major and the minor, the levator levi superioris and the levator levi superioris elegans, these three muscles are all attached to the lip. So if you want to inject this part, this is a very dangerous zone for the Botox, because if you touch any of this muscle, so the action of these muscles pulling the lip will not be there, right? So what will happen? The lip will go down. Now when you look to the muscular lower part of the face, these are known as a sad muscle group. There are three muscles. Basically, Shilpa mentioned DAO, depressor angularis oris, the depressor levi inferioris, because we have levator levi superioris, right? It should have an antagonist. So depressor levi inferioris and the mentalis. So if you touch this group of muscle, so the the saddened look is not there. So if you want someone to have a nice smile going up, you should touch the DAO. Then what will happen? The zygomaticus and the superioris group of muscle will just pull it up and it will give a better look. So every muscle, if you know which is the agonist and which is the antagonist, it helps in a better results.
So starting with the next talk in line, the botulinum toxin injections for facial rejuvenation. As we all know, eyes behold the attraction on the face. Eyes are the main thing which attracts someone towards your face. There are many age-related factors which affect eyes, the thin skin around the eyes being the main thing which leads to this. So we used to have patients for blepharochalasis complaining that they want a better look. Then patients used to come, even male patients, with worry lines, and they used to say that we have these lines and I want to do something about it. And we all know we have young patients which want something to be done to their eyes so that they can beautify themselves up, use some makeup on their eyes. So the Asian blepharoplasty, which we all know. So we are seeing that the trends are changing. There is desire to look young. Now the treatment is more readily available and is more acceptable, and society is more aware of it. And there is little more disposable per capita income, so people are trending towards it. And there is a shift now from surgical to non-surgical procedures, especially since the fillers have started to come. And there's want to look more natural. More men are coming in for procedures, and younger women are now seeking treatment. It is not that now I'm 50, so now I should try to look like 30. So they start at 30 so that they keep looking like 30 till their 60s or 70s. They want this now. And there is growing acceptance, as I said, towards aesthetic treatment. It is not that you get a rhinoplasty done or any non-surgical procedure done and you say, no, I just look like this. I never got anything done. It's not like this. People say, yes, I got it done. I got it done like this. From here, it took so much time. This was the downtime. Don't do this and do this. So people are discussing these things also now. The American Society of Plastic Surgery, 15.9 million cosmetic procedures were recorded in 2015. This is the largest data available till now. Next 2020 it will come. And 14.2 million were non-surgical. So the non-surgical procedures consisting of neuromuscular injections, that is Botox, botulinum injection, and fillers are the most common now. The non-surgical aesthetic treatments like botulinum toxin, dermal fillers, chemical peels, layer hair removal, and microdermabrasion. And Botox or botulinum forms the 47% of all the treatments. There is a considerable high increase in use of botulinum toxin and fillers since year 2000, as has been noticed. Because of ease of procedure, fear of surgery and anesthesia is not there. Patients don't want scars on their face, obviously. It is in their budget, and lack of available downtime. One more thing is they are kind of reversible. The effect of Botox will go after some time, kind of fillers, the effect of fillers will also go back after some time. So you can always counsel the patient that get it done. If you don't like it, in any case, you're going to become the way you are now in some time. So it is linked to its non-permanent nature, actually. I'll skip all this, it's becoming, so there is increasing employment opportunities in now South Asian countries and higher disposable incomes, as said. So that's why there's demand for aesthetic procedures, which has increased now. Just want to skip all this. So botulinum toxin actually was once touted as a poison, but it's now safe and effective medicine. And as a poison, the dose of botulinum toxin should be very high as compared to what we give. We do not inject more than 50 to 100 units in a patient, and the toxic dose is around 5,000 units. So we need not worry. And as we were discussing yesterday, that if we take 1 tablet of paracetamol, and the toxic dose is 20 tablets of paracetamol. So we take paracetamol so easily, like we take it almost once a week also we can take paracetamol. And the toxic dose of botulinum toxin is like 1,000 times more than what we inject. And we are scared of doing or getting botulinum toxin done. It has 8 antigenically distinguishable exotoxins, and type A is the most potent. It is easily producible in culture, highly purified, stable and crystalline form, and has longest duration of action. The mechanism of action we all know. I think we can skip this here. And the peak paralytic effect on the patient will come after 4 to 7 days clinically. And after doing botulinum toxin injections, call the patient for follow-up after 10 days or around 2 weeks. I usually call around 2 weeks because that is the time when you can see the best result. And the effect will go in on an average 3 months. That is it. So there are collateral axonal sprouts which emerge and extend towards the neuromuscular junction, establishing its efficacy again. That's why the effect is reversible. Also, there is formation of humoral antibodies leading to decreased effect of the toxin over time. That's why you must always give the smallest dose which is required for that patient, because you need to repeat it every time, and the time interval between injections should be maximized. Even for your blepharospasm injections, this should be the same. You must give the smallest dose at which blepharospasm is stopped, and the patient should be advised to do some pranayama and yoga, maybe if it helps to prolong the duration between the 2 sittings of injections for blepharospasm also. So commercially available, I use Botox, no financial interest. There is MyoBlock available and Dysport also available. Botox comes in a sterile, vacuum-dried, purified extract of botulinum toxin type A, produced from fermentation of Hall strain of C. botulinum. And this dried toxin A has to be stored at -5 degrees Celsius until it is reconstituted. Reconstitution for 100 units vial, if you reconstitute it with 2 ml, it will give 5 units per 0.1 ml of injection. So you can formulate something for yourself which you find helpful. I initially started with 4 ml in 100 units vial. Now I am putting 2.5 ml in 100 units vial. So basically my practice has changed a little bit, but you can just start with a low dose and then go with higher dose later. So methods of reconstitution. This is a 50 units vial. This is how it comes. Very easy to open. Take out the vial, check for the batch number, etc. You must always write the date of opening the vial, although we don't use it later, but now it's a practice. It has been seen that for 7 to 10 days initially, or 2 weeks, nothing happens. You can use the Botox within 2 weeks. So reconstitute it with normal saline. Don't use distilled water because it will pain when injected. And when you, as seen in the video, when you inject the normal saline, since the vial is vacuum dried, the normal saline goes automatically in. that is also a check that the Botox has been produced, and checks that it has not been opened initially, because actually you can't see that dried Botox in the vial, it looks empty. Contraindications, obviously neuromuscular junction abnormalities, do not use Botox. Don't use Botox for in patients who are having pregnancy or areas of active infection, known hypersensitivity to ingredients, and egg allergy, as Botox has albumin. So we use Botox for facial wrinkles, both dynamic and static, but static obviously will be helpful more with fillers, not with Botox. As seen, this male patient has these, because of frontalis muscle overaction over the years, and these worry lines in between the eyebrows. This lady also. And aging does all of this. This is most common to get horizontal lines, crow's feet. Before you start, take an informed consent. Temporary nature of the correction must be explained, and precise documentation of treatment site and dose should be done. General injections: apply Prilocaine, Prilox to the skin, give ice packs, avoid chemosis and pain. Ecchymosis can be avoided by injecting subcutaneously where the skin is thin, and avoid fine subcutaneous vessels. Cooling the skin before and after the treatment will also help. When you're injecting and when you're documenting, taking the pictures of the patient, ask the patient to contract, come in animation, and then inject, because it helps in effective uptake of the toxin. Our aim is to weaken the muscle and not paralyze. Patients are assessed, as I said, 2 weeks after the injection. So these are the glabular frown lines. The muscle will contract vertically and will produce, the frontalis muscle will contract vertically and will produce horizontal lines, and the glabular frown lines, as we can see here, are produced because of contraction of the corrugator supercilii procerus muscles. These are the injection sites. I'll be showing this video quickly. Hold the muscle, the muscle bulk in your hand. This is the injection for corrugator. Go deep here, and superficial when you're going in the superficial head. For crow's feet, inject outside near the lateral orbital rim, around 1.5 to 2 centimeters away from the lateral canthal angle, and avoid zygomaticus major muscle also. You can either take 3 points or 2 points injections in the crow's feet. The contraction of lateral orbicularis fibers, zygomaticus and risorius muscle produce this. So 3 to 4 injection sites of 2.5 to 5 units of Botox are helpful. Go subcutaneous over the orbicularis muscle and inject. Always raise a bleb. It is helpful to raise a bleb and form that Botox bleb over the muscle. When you're injecting in corrugator, be bevel up, and for blepharospasm also, when injecting in the lids, then stay bevel down, like go in, rotate your syringe and go bevel down. For forehead lines, the contraction of frontalis muscle gives forehead lines, and 4 to 8 evenly placed sites 2 to 3 centimeters above the orbital rim are chosen. The botulinum toxin, if spreads down, can cause ptosis. So around 2 centimeters, 2 finger breadths away above the your eyebrow, you should mark the points. And the diffusion circle of Botox, according to the reconstitution you have made, it is around the 2.5 centimeters diameter. So must place the injection sites like this. This is a small video showing. Don't go laterally, you might cause a spoke eyebrow. Usually inject 1 to 2 units per site. Eyebrow is a dynamic structure because it has the elevators and the depressors. So if you inject here more, this thing will be taken up and a spoke eyebrow deformity will be there. If you inject here more, the eyebrow will be flattened. So the dynamic thing between the muscles, it plays role between the elevators and depressors. Inject carefully. This is just to show that eyebrow actually is very important for facial beauty. So this line from ala of nose to the center of the brow, stay medial to it, else you might cause any of these. So these are few patients who have been injected for crow's feet, like whole upper face Botox has been done. So see, the crow's feet have decreased here. For bunny lines, hold the muscle again similarly. Inject. So if when you inject for crow's feet, if you injected more hair and you have not done hair, you might cause a chipmunk face. The face goes medially little and it enlarges hair. So the chipmunk face is created. For bunny lines, avoid injections into elevators of upper lip. Perioral, dynamic muscle actions associated with eating, drinking, speaking and smiling may be impaired. So cautious approach in this area. Take smaller doses initially. Do not inject very deep and inject in the depressor anguli oris. Don't go to labii inferioris. Treat conservatively, inject symmetrically, avoid midline of upper lip and stay within 5 millimeters from the vermilion border. Platysmal band, similarly, we can inject Botox in small doses at the multiple sites.
Shilpa, just
last slide, ma'am.
Okay.
So for masseter hypertrophy, this is the last slide. Mark, I think we can take up this separately, how to mark and everything. Go deep into the masseter muscle and inject at various sites. So, this